Assalamu alaikum. Today we will continue upper cervical injuries part 2. First one is atlantoaxial instability. It's the same as occipitocervical regarding causes, traumatic or acquired. Acquired causes, there was rheumatoid and down. Here there is some other causes we will see later. It could be atlantoaxial instability is instability between C1 and C2, either rotational, C1 rotated over C2, or translated, C1 translated mostly anteriorly over C2, or vertical translation, vertical. Type A, which is rotation, usually non-traumatic. The usual scenario is a child sleeping normally, then on the morning, his or her parents seeing that his neck is tilted, torticollis, without even a pain. This is classified according to fielding, either type 1, 2, 3, 4, according to the degree of displacement of rotation, either 3 millimeter, 3 to 5, 5, more than 5, and posterior translation, rotation. As I inform you, the usual scenario is a child. You will manage him conservatively. We will continue his management just in a while. But other cause of this torticollis could be infection. So one important question to ask here about infection, like otitis media, common cold in the recent days. And there is a rare type of infection called Grissel syndrome, retropharyngeal bursitis. And all of, after excluding trauma, after excluding infection, if this child has a mild form of torticollis without midline pain, you can just give him a soft collar and tell him to go home, and in the next OBD, nearest OBD, you will see him again. This is if presented to you within 1 week. If after 1 week you have to admit, you have to do a CT to confirm that this rotation is spontaneously reduced as a usual. This spontaneous rotation is reduced and there is no translation, rotation, and you will keep him in the hospital on a traction of his neck attached to the bed, and follow him. If this torticollis decrease gradually, so he is okay. If not, which is very, very rare, or presented to you after 1 month, you will fuse him. Posterior, of course. One of other rare causes of this rotation, os odontoideum. Odontoid, or C2, is formed with of 5 ossific nucleus. 2 for the neural arch, 1 for the body, and 2 for the dentist. The dentist is 2 halves, right and left. In between the dentist and body is synchondrosis, usually fused at 6 years. And here another synchondrosis fused at 12 years. So if you see an X-ray, or the examiner show you an X-ray with fused this part and not fused this part, this child is above 6 and below 12. This is also another rare cause of instability. Uh, Type B is translation. The main stabilizer of C1 and C2 is transverse atlantal ligament, could be injured, either type 1 or type 2. Type 1 is bony avulsion, for sure. You will manage him conservatively as all other cervical injuries. Type 2 is mid substance, usually he will need operation. There is instability here. There is a translation of C1 over C2. The anterior atlantodental interval here is exaggerated, is enlarged. So you will do CT and you find that this is an avulsion part of transverse atlantal ligament. So usually you will manage him conservatively. I will tell you later why this case is fixed. Translational injury is a high energy trauma and usually unstable, but if you have bony avulsion, you can conserve him either even with Miami G collar or hollow vest. But if after, for example, 3 months, you do a flexion extension radiograph and you see still there is an opening in atlantodental interval, anterior atlantodental interval, so you will fix him. This case, after conserving him, he did a flexion radiograph, he found that still unstable, so he fixed him. So, anterior atlantodental interval more than 3 millimeter on flexion radiograph. After 3 months, he will fuse him. Okay, type C is a destructive injury. Destructive injury, same as cervico-occipital dissociation, managed the same. The usually operative is if he is still alive, and the hallmark is instability and radiology, the key words. Here C1, here is C2, vertically unstable, and also there is subtle instability here. Usually they are associated very high energy trauma, and usually this patient die. If no, for sure you will fuse him posteriorly. Craniocervical. Okay, odontoid fracture. Second part of this lecture, odontoid fracture. Odontoid fracture, Anderson classification. Odontoid has a tip Anderson like this, and occipital condyle fracture also has a prominence and Anderson classification also. Has the same classification. Anderson classification type 1, type 2. Type 1 is the apical part of the odontoid. Here attached the apical ligament and here is the alar ligament. Usually this is stable injury. But you have to be sure that this not a part of craniocervical dissociation. Mostly is stable injury. This is type 2 injury. Type 2. Type 3 is here. Type 2 is here. The hallmark is the facet. If above the facet is type 2, is below below the facet, it is type 3. Type 3 extended to the body. Okay. Type 3 extended into the vertebral body below the lateral mass. Type 2A is the comminuted part of type 2. This is extended to the body and below the lateral mass. Type 2 is above the lateral mass. For sure is a common viva station. as usual, all treated non-operatively except type 2, either in elderly because he can't withstand hollow vest, or young with high risk of non-union. What is the risk for non-union regarding type 2 odontoid? This list you have to keep in mind either more than 5 millimeter displacement, angulation more than 10, 15, 50 years old, man with comminution, smoker, and delay in treatment. This is the displacement how you can measure. This is the anterior part. This is the sagittal CT. This is the anterior part of the proximal part, anterior part of the distal part, the transverse or horizontal distance between them, either from the anterior or posterior, but angulation should be posterior because the anterior border of the odontoid is curved. Little bit posterior border is straight. One is parallel to the proximal border, to the posterior border of the proximal fragment. One other line is parallel to the posterior border of the distal fragment, and you measure the distance. Usually, if more than 10 degree angulation, more than 5 degree displacement, this is unstable injury and more prone to non-union. Also posterior displacement. This is proximal part posteriorly displaced. You can fix this either anteriorly with anterior odontoid screw like this from here to there after reduction, or fusion here posterior. So it can be fixed anterior or posterior, depends on what? Depends on the bone quality. Anterior odontoid should be non-comminuted, so it can't be done in type 2A. Bone quality is good, can't be done in osteoporosis, and has no barrel chest. What is meant by barrel chest? Appropriate body habits. You have to incline your hand mostly on his chest. So if his chest is protruded anteriorly, it will interfere with your angulation. So if his chest here is here, so your screw, your guidance screw will be like this. So you willing to catch the anterior, the proximal part. So anterior odontoid screw needs intact bone without comminution and good quality, and also good body habits. So posterior in the reverse, usually posterior in the reverse. In the reverse, if comminuted, if osteoporotic, if unfavorable body habits, you will fix him, fuse him posteriorly. And also in another part, reverse obliquity is the same concept of reverse obliquity in subtrochanteric. You can't do DHS in reverse obliquity. Why? Your screw is parallel to the fracture side. The same here. For example, this is the usual pattern of the fracture. Proximal anterior line extended distal posterior line like this. So the screw is perpendicular here to the fracture line. If it is reverse like this, the proximal posterior to anterior distal, your screw will be parallel to the fracture side. Either it will displace it more or it wouldn't catch the fragment at all. So it is contraindicated, so you will fix posteriorly. This is the anterior screw, this is the anterior screw, and this is posterior type of fixation. You now know a lot of types of posterior fixation. Please review upper part lecture and cervical, upper cervical anatomy lecture. There is something wrong here. This is the anterior part of the Dennis, atlas, sorry. And this is behind it, behind this part is the Dennis. This is the anterior border and this is the posterior border. There is some displacement here. So we did CT, we found this. There is a fracture odontoid, mostly type 2. If you want to fix this fracture, you will fix anteriorly or posteriorly. Mostly you will fix posteriorly. Why? There is marked osteoporosis. Again, this is a fracture odontoid, mostly type 2. But when we did MRI, we found a signal, ligamentous signal, ligamentous injury. There is a signal here, so you can't do anterior screw only. Anterior screw is weak to control posterior failure also. There is anterior failure and here posterior failure, so you have to put 4 screws or 2 screws transarticular. Here he put C1, C2 fusion, 4 screws. The last part, traumatic spondylolisthesis. Please, again, this is a fracture through C2 part. Please review the anatomy. Please review anatomy of upper cervical injury. Classified through Levine. This is a common vivastation. This is the bar. It is fractured. This is type 1. As you see here, type 1 is displacement less than 3 millimeter. There is a typical part of Hagman fracture, very rare, asymmetrical fracture. As you see here, a fracture in the bar, but here it is translated to the facet. So in the lateral view, one part of the fracture is overlapped with the other, so hardly seen in the X-ray. And in the same time, you feel that the bar is elongated in X-ray. Of course, this is a high energy trauma. He coming to you in the ER with, for example, motor vehicle accident. So it is high energy trauma, and he feel midline tenderness through examination. So you suspect something, so you will do CT to see this and declassify it. Type 1 is easily detected in the X-ray, plain X-ray. This is part of the atypical type 1, as you see a fracture in the bar here in the axial CT, and here through the facet. Here, there is maybe radiolucency here, but still in continuity, because one of fracture overlaps the other, but the bar is elongated. The next type, which is type 2, displacement more than 3 millimeter. This displacement more than 3 millimeter. There is also a typical type of type 2, and this is which is coming to you in the Viva exam. Why? Here there is a displacement more than 3 millimeter, but actually there is no translation here. Instead, it is a lot of angulation. Actually, the disc is disrupted. So, if you did a traction, if you will either exaggerate the deformity, there is no ligamento-taxis here. Either exaggerate the deformity or you will do a traction over the cord. The patient is in risk. So, they give you this X-ray to avoid massive injury for the patient. Actually, he will die. So there is marked angulation here, but there is no translation. Displacement here is more than 3 millimeter. So this type is contraindication for traction. Type 3, very rare, bilateral C2-3 fracture dislocation. This is the facet of C2, and this is the facet of C3. It is dislocated anteriorly. Be careful. In the X-ray, it will appear as if type 1. As you see here, is little displacement less than 3 millimeter. So don't ignore this part, posterior part. CT, the type 2, C2 is displaced the anterior in relation to C3. Here there is some radiolucency here, but everything is okay. I can manage him conservatively. I did in the same time flexion extension X-ray, see how it is displaced and what facet dislocation is more apparently here. So it is a fracture dislocation. Usually this needs operation. Other parts is as usual conservatively managed successfully. So the surgeon prefer to do C2, C3 fusion but anteriorly. Indication for surgery, as usual, all patients or with upper cervical injuries mostly will be managed conservatively. So type 1, type 1A, even type 2 is mobilized either in Miami J collar, Miami rigid J collar, or hollow vest. This is a conservative management, but for all conservative management in the cervical spine, after completing the 3 months, you will do a flexion extension radiograph and measure the instability and see if there is instability or no. If there is instability, so you will fuse him. Type 3 for sure, he needs stabilization, fixation. Either it can be done anteriorly or posterior. Anterior through C2, 3 ACDF, or posterior either C1 to C3, C2 to C3. If you can hold the screw in the C2, it could be comminuted C2. The fracture already is here, so it is technically demanding. You can go escape this part and go C2 to C3. The surgeon tried to take C2 because he want to preserve motion between C1 to C2. But if there is risk to take a purchase through your screws, so you will go C1 to C3. C2 to C3. This is C1, C2 to C3. C2 bars is fracture, so you better to go to the pedicle. Please review the other cervical anatomy and upper part injuries. And this is the lateral mass of C3. So what is this type? This is after as usual taking a proper history, ALTS protocol. I need to see X-ray. There is no X-ray. This is CT. CT here is mostly extended to the body, so it is type 3 below the facet, so it is type 3, so it can be successfully managed conservatively. What is this type and how you will manage? Please try to answer it in a comment, and please Be sure to subscribe to channel to receive the new videos. Thank you so much.